Good morning and welcome everyone to the 2021 NHMA National Hispanic Health Conference. I'm Dr. Minerva Romero Arenas. I'm a general and endocrine surgeon, and I'm very proud to be a part of these workshop sessions, which we have set up in partnership with the Latino Surgical Society. As a point of note, please note that we will have all microphones muted during the session. We will have the stellar presentations followed by a brief question and answer discussion. And a recording of the session will be sent out to all of the attendees. We do ask that you please fill out the CME survey that will help us plan future events, and the instructions specifically for CME will be provided in the chat box. So it's my pleasure to introduce to you our first workshop, which is a surgical spotlight on Latino healthcare. Today, we're going to have Dr. Virginia Oliva-Shaffer, Dr. April Mendoza, Dr. Jonathan Villena-Vargas, and Dr. Chantal Reyna, who will be sharing with us a variety of topics. Dr. Mendoza is an assistant in surgery, trauma, emergency surgery, and surgical critical care at Massachusetts General Hospital, as well as co-director of surgical nutrition. She's an instructor in surgery at Harvard Medical School. Her research focus is translational surgical immunology with an emphasis in alterations after trauma and emergency surgery. Dr. Mendoza attended Loyola University Stritch School of Medicine, where she earned her medical doctorate. She obtained a master's in public health at the Gillings School of Global Health at the University of North Carolina. She also completed a fellowship in trauma and surgical critical care at the University of California, San Francisco. Dr. Jonathan Villena-Vargas is a thoracic surgeon. Currently, he's a clinical instructor of thoracic surgery in the Department of Cardiothoracic Surgery at Weill Cornell Medicine in New York City. He received his bachelor's degree from the California Polytechnic University in Pomona, California, and his medical doctorate from Loma Linda University in California. Dr. Villena-Vargas underwent a general surgery residency at Mount Sinai Health System in New York and a fellowship in translational research at Memorial Sloan Kettering Cancer Center, also here in New York. His work during that time focused on cancer immunotherapy, specifically CAR T-cell immunotherapy approaches for thoracic cancers. He then went on to complete a fellowship in cardiothoracic surgery at Weill Cornell Medicine in New York City. His interests include minimally invasive approaches in thoracic surgery, immunotherapy for thoracic malignancies, and cancer disparities in the United States. Our third panelist is Dr. Virginia Oliva-Shaffer. Dr. Shaffer is an associate professor of surgery at Emory University in Atlanta and specializes in minimally invasive and open surgical treatment of disease of the colon and rectum. She received her medical doctorate from the University of Texas Health Sciences Center at San Antonio and completed general surgery residency at Emory University. She completed a research fellowship in transplant immunology and subsequently a fellowship in colon and rectal surgery at Cleveland Clinic in Florida. She's board certified in both general surgery and colon and rectal surgery. She's a fellow of the American College of Surgeons and the American Society of Colon and Rectal Surgeons. Her research interests include health services research, quality improvement, and clinical research. And last but not least, Dr. Chantal Reyna is our fourth panelist. And Dr. Reyna is an assistant professor of breast surgical oncology at the University of Cincinnati. She is a fellowship-trained board-certified surgeon specializing in diseases of the breast. She received her medical doctorate from the University of Nevada School of Medicine and completed general surgery residency at the University of Nevada Medical Center and Children's Hospital. Following her passion for breast cancer care, she pursued a fellowship in breast surgical oncology at the H. Lee Moffitt Cancer Center and Research Institute in Tampa, Florida. She has been practicing at University of Texas MD Cancer Center until her pursuits led her to the University of Cincinnati. Her research interests include minimizing axillary surgery. She has received many honors, including the University of Nevada School of Medicine Surgery Student of the Year, Chairman's Professional Conduct Award, and the University of Nevada Heart of Gold and Alpha Omega Alpha recognition. She's a member of the American College of Surgeons, the Society of Surgical Oncology, the American Society of Breast Surgeons, and the Association of Women Surgeons. She's also a member of the Latino Surgical Society. She holds committee positions in several additional organizations, is an avid soccer fan, and enjoys reading and traveling internationally. So we have a stellar lineup set up today. And if we are ready, I will turn it over to Dr. Mendoza.
Thank you so much. Today, I was given this wonderful topic that I do every day. I'm a trauma surgeon and a critical care intensivist. And the spotlight is Latin and Hispanic health in trauma and critical illness. This is an expansive topic that I can't give justice in 8 minutes, but I will definitely try. Next slide. I have no disclosures. Next slide. So the objectives will be just to introduce Latin and Hispanic health needs in the trauma setting, to disparities in COVID-19 in La Comunidad Latina, which I know was spoken at length earlier in this conference, but I feel like I would be remiss not to talk about it as an intensivist. And then finally, to appreciate rehabilitation and recovery services that definitely affected the COVID-19 survivors, as well as my trauma patients as well. Next slide. Okay, so I don't know how many people of my participants are trauma surgeons or interested in trauma, but I think just to describe who these patients are, they're typically male. 70% of trauma patients are. The most common cause of death in Americans is actually trauma. And that usually affects the young from ages 2 to 44 years of age. Often they are working class, they are typically marginalized people in our society, they're typically vulnerable, and this is how the elderly get involved as well as the very young. And then frequently they're underinsured. As you can see from this slide from the CDC, the Hispanic population is underrepresented in motor vehicle and firearm violence, but which I will kind of allude to as the Hispanic paradox. Next slide. So, compared to non-Hispanic whites and non-Hispanic Blacks, outperform or have better or less frequently have unintentional injuries or violent injuries. I would argue this could be good news. This may represent another component of the Hispanic paradox. However, as a trauma surgeon, I think that this injury patterns and is often underreported, and they're not captured by current day's research. Think about TQIP and NSQIP. I feel like I think the people who review data often can't identify patients are because we are a diverse group. However, I think it also worth looking into further how social and community factors may also involve the fact that trauma is less frequent in this group of patients. Next slide. What has been shown in the literature pretty clearly and for multiple years is that work-related traumatic injuries disproportionately affects the Latino population. In this study that was published in Oregon, it found that 2.6 that Latinos were 2.6 times more likely to experience work-related injuries when compared to their white non-Hispanic counterparts. And uniquely, the vast majority of these patients had injuries related to falls. Unfortunately, over their time course of their study, looking from 1998 to 2008, this is a 2012 study, they found that these injuries were actually increasing and not decreasing and disproportionately affecting the Latino population. This is a picture of a patient of mine who sustained a work-related injury that resulted in a very complex abdominal injury that had a difficult time actually performing the abdominal wall closure. He had abdominal compartment syndrome, and ultimately he was sent to me to facilitate a complex wall reconstruction. Next slide. What recently has come out in the last 3 to 5 years is that workers' compensation is actually providing less and less coverage to people who sustain injuries at work. Unfortunately, this disproportionately affects Latinos as well, because Latinos are more likely to utilize workers' compensation when compared to other groups. And they have a disproportionate lack of private insurance when compared to other patients. What we know from the National Trauma Data Bank research is that insurance coverage matters. People who have less coverage have higher mortality. So this, again, puts this patient population at a particularly high risk for worse outcomes. Next slide. I would be remiss not to talk about something that's affected my life over the last year as a critical care intensivist. You know, when I looked at the slide that was published by the New York Times early in 2020, looking at the month of April and May, in March, in Boston, this had completely taken over our lives, where we had anywhere between 400 to 500 patients in the hospital. And every component of our lives was kind of surrounding how to manage COVID-19. And then when you flash forward to 2021 and you see January data, looking at the triple peaks that we've sustained as a country, the numbers are actually now at this point, they're unmanageable. They're just we're talking about millions of people and about over 500,000 deaths. Next slide. Unfortunately, COVID-19 has affected Native Americans and Latinos more than other groups, and the case numbers, hospitalizations, and death rates have been disproportionately affected these groups, in particular the Native Americans and Latinos. Next slide. There's been multiple commentary within the literature talking about this experience, and I could definitely comment on MGH's experience as well, but I think this sums up the intensivist experience overall. But out of 18% of the total population in the country is Latino, 28% of all COVID infections are Latinos. And unfortunately, this is underreported because 31 out of 50 states report on ethnicity when they comment on case numbers. This has been illustrated beautifully yesterday in the COVID-19 social determinants talk, but as a critical care intensivist, we saw multiple patients who had coexisting medical conditions like diabetes and hypertension, and this disproportionately, unfortunately, affects Latinos. Access to healthcare was a huge component of outcomes here, where 19% of Latinos are uninsured as compared to 5% of the non-Hispanic white population. And ultimately, immigration status had a large swath of influence and who accessed care and when and at time people presented to the hospital. Language barriers were not insignificant. 30% of Latinos are non-fluent in English, and this definitely presented a barrier to how we delivered care to the patients and their families while they were in the hospital. Work conditions and financial burdens have been mentioned as well. Telecommuting was part of life for most of, but 32% of Americans can actually perform telecommuting compared to 16% of all Latinos. And then living in undomiciled conditions. The reality is multi-generational housing is not uncommon, and not having a domicile, having an address also puts barriers in how you are identified by healthcare workers, and it prevents a barrier to reporting and identifying cases. Next slide. This is a perspective piece published by Johns Hopkins looking at COVID-19 and the undocumented population that they were serving. You know, Hopkins' experience is not unlike MGH's, where pre-COVID, 5% of patients had a Spanish language preference. Post-COVID, however, we recognized, as well as Johns Hopkins, that communication barriers were a large barrier and a huge challenge to providing comprehensive healthcare to the patient as well as their families. They comment and they give a little shout out to us in their perspective piece about the MGH team that we developed called Juntos, which is actually it was a consult team of volunteers. These were physicians, radiologists, orthopedic surgeons, gynecologists, social workers, nurses. This was all volunteer time. They were all native speakers. They went in the hospital to talk to patients and families. This was all people working free of charge. They were not being provided any resources for this, but it really showcased to MGH as well as Hopkins how little resources we have for interpreters. And this was a huge challenge pre-COVID and remains a challenge, but during COVID this was a matter of life and death at some point because people were not getting adequate information in a timely fashion. Unfortunately, there's a history of systematic exclusion of safety net services in this country, and it was point and center in the last presidential administration. And patients frankly feared utilizing available resources. They feared consequences. They feared deportation. Housing instability, they mentioned as a huge problem for their Hopkins experience. And I could say from MGH, it's very much the same, where multi-generational housing was part of every immigrant life, regardless of whether they're Latino or not. And this disproportionately affected this patient population. And then finally, financial concerns. Most people don't think they can afford, a 2-month hospital stay and don't want this burden on their families. And so we're presenting later and later in the course of their disease. Next slide. As I kind of move on to concluding my talk, I feel like I had to bring this up as well because it definitely affects COVID-19 population, but it affects trauma patients as well. And this is the reality of disparities when it comes to discharge and disposition. We know that physical medicine and rehabilitation services change lives, particularly when they have life-altering diseases. This is a 10-year review that was published last year in 2020, looking at 49 studies, and it looked into stroke, traumatic brain injury, spinal cord injuries, as well as hip fractures. And I'm going to focus really more on traumatic brain injury and spinal cord injury as a traumatologist. But in general, what they found was that when it came to these types of injuries, there were less access to care. These patients were being less often referred to rehabilitation services. And this is where, as physicians, we come into play. We can consider offering these services and pushing for these services. Whether there's a family pushback or not, I think it's our role to kind of illustrate the advantages that this type of services provide. Additionally, they found that there tended to be worse functional and neurologic quality of life scores, not typically at discharge because of this Hispanic paradox, which was alluded to earlier in the talk in the session, but at 1 year discharge. At 1 year post-discharge, there tended to be worse neurologic quality of life scores, particularly in those patients who did not live with other English speakers. Also, there was evidence of more depression, particularly in Black and Hispanic patients. Looking at spinal cord injury, they found again that they typically did better at time of discharge when compared to non-Hispanic whites and African Americans. However, at 1 year post-discharge, they think there was a ceiling effect because of a lack of outpatient to this patient population. So they tended to have less physical independence after spinal cord injury when compared to non-Hispanic whites and African Americans. And there tended to be smaller gains in post-inpatient discharge. Next slide. So I want to thank you very much for your time and for this opportunity to talk. I find this is a very small snippet and a very comprehensive topic. In general, I think trauma injuries are underreported, and there's data capture opportunities that exist to better serve trauma patients, particularly Latino trauma patient. COVID-19, I think, was taking a Band-Aid off of the reality, which is the US healthcare system, which is access to care is a huge determinant who does better after an injury or an infection. And then also recovery. I think we have opportunities to improve, and as clinicians, we can refer these patients to appropriate services post-discharge. Thank you again for your time. I'll take any questions.
Thank you so much, Dr. Mendoza. I'm going to ask the audience if you can please submit questions in the Q&A box. In the meantime, I'm going to ask Dr. Villena to go ahead and set up his slides. Thank you so much for that wonderful presentation. I will ask if the audience can please submit the questions through the Q&A box, and we'll take the time to answer the questions after all the speakers have had a chance to present. Thank you so much.
So I'm Jonathan Villena-Vargas. I work here at Cornell along with Minerva, actually. I'm a thoracic surgeon in the Department of Cardiothoracic Surgery. And, one of the projects, I'm mostly interested in cancers, as most thoracic surgeons are. And one of the projects that I'm interested in is looking at different mutations and seeing disparities in these different mutations. So I'm going to share some of my work here. So here we're looking at EGFR mutations in US Latinos with lung adenocarcinoma and kind of the prognosis and, what it really means to our community here. So I have no disclosures for this project. So in actuality, we've been doing a pretty good job with lung cancer. Here as a New England paper from last August. In red, you see the incidence-based mortality for lung cancer in all comers in the United States. And you can see that it's been dropping since basically early 2000s. And the drop is actually picking up its pace We're looking at men, like deaths due to cancer in men. It's actually dropped to about 6.3% per year since 2013, which is pretty astounding. So this is not an incidence dropping, meaning that there is a population that the population as a whole is smoking less. But these are patients that actually have cancer and their mortality from lung cancer. And the surgeons can try to take credit for this, but it's really mostly about targeted therapy and immunotherapy that has come out in these last few years that has really changed the paradigm for lung cancer. One of the most important mutations found, which was found around 20 years ago, is EGFR. It's found in a small subset of non-small cell lung cancers and lung adenocarcinomas. And the reason that this is important is because they find out that they have a sensitivity to TKIs, and there's different generations of TKIs, and these patients that have this mutation respond well. And then additionally, another reason that this specific gene mutation is important is because it can give you a resistance to immunotherapy, which in the last 10 years has also really changed the face of how we treat lung cancer. So this is an important kind of mutation that drives trials, meaning that, which way, with what treatment should a patient get. And that's really important, especially now as a surgeon when we're doing a lot of neoadjuvant trials. So we give patients immunotherapy prior to operating on them, with the idea of decreasing recurrence. We can take the cancer out, but about a third of these patients recur. So this is a really important mutation. A lot of the literature on this specific EGFR mutation is actually from East Asia. They found out that around 40 to 60% of Asians have this mutation, and around 15% of Black patients, around 15 to 20% of white patients have this mutation. So it's really important in Asian patients. It's really prevalent among non-smokers. It's really prevalent among women. So, the way you learn about it, they say, if you have a female non-smoking Asian, the chances of that patient having this mutation is really high. So actually those patients, we will exclude them from immunotherapy trials because statistically it's so high. So that being said, no one's really looked at this in US Hispanics. There's been a couple of people that have tried to look at it, but the results are kind of all over the place and not really, they kind of, some of them say higher, some of them say lower, so nothing conclusive has been said about this. However, I mean, if you take it out of the US and you look at Latin America, there's this consortium of a bunch of Latin American countries. And, they did actually, with Boston's help, look at, this EGFR mutation in different Latin American countries. You guys can't see my pointer, but basically what they found was that there is an increase in this mutation associated with the female gender, just like the Asians, the non-smokers, just like the Asians, and also the indigenous population. So that's very interesting because I think that conceptually is a difficult concept in the US. If you speak to a non-Hispanic person, they lump kind of Latinos together. It's kind of an ethnicity, but it is also a breakup of races, right? And you can tell this by looking at the countries. So Mexico and Peru, which have a larger indigenous population, a larger mestizo population, their EGFR mutation rate goes from 36 in Mexico to 50% in Peru. Compared to Argentina, which has a much lower indigenous or mestizo population, they're mostly European immigrants. Their mutation rate is actually 14%. So that's a very big difference, and conceptually that's something that it's difficult in the US. So that was found to be higher. So no one's really looked at this in the US. So we started looking at our own database. So we have these early stage cancers that we resect and we keep the tissue. We started doing mutational analysis routinely back in 2015. So we looked at this, we analyzed these tissues for EGFR mutation. We stratified the patients based on race and ethnicity that's self-identified. Some were excluded that, they either didn't want to mark down their race/ethnicity. And then we did, typical statistical analysis. So we identified around 1,000 patients from this time period. We excluded some that were non-lung adenocarcinoma. We excluded some that the race and ethnicity was unknown. So in the end, we had around 670 patients that have a known self-identified race and ethnicity. And we kind of broke them up into groups, which are Asian, Black patients, Hispanics, and white patients. So what we found was that, you know, in New York City, at least in the Cornell cohort, the Hispanic patients did have a higher EGFR mutation rate, around 35%. The white patients or the Caucasian patients had around 15 to 20%, which is known in the literature. Our Asian patients, which we have a lot of, was around 66%. Also goes along with the literature, and our Black patients are around 20%. All the pathological stages were all similar. They were all compared. They were all resectable early stage lung cancers. So we were able to see a higher amount of EGFR mutation in Hispanic patients. They also were less likely to be smokers, and they were actually, you know, female predominant. When we compare the overall survival at 3 years, you don't really see much of a difference. All these patients did pretty well up to 3 years, which is good. But the interesting thing is when we started looking specifically at the patients that had these driver mutations, this EGFR positive population, you see in blue that the Hispanics actually did much worse than the Asians or whites, much worse, with a overall survival of 62% versus 96 and 90%. So that was very intriguing. And when you look at the wild type patients, the Hispanic patients actually did a little bit better. In blue, again, you see in both overall survival and disease-free survival. So there may be a difference biologically in these cancers between the different races, which we thought was very interesting. There's some studies that look at, there's 4 common variants in this EGFR mutation located in different exons. And there's some studies that show that, maybe some exon EGFR mutations do better than others. But we didn't really see a difference as far as the races go or the ethnicities go with regards to which exon has the mutation. So kind of the take-home points is that, there is a difference based on ethnicity and /race with lung adenocarcinoma and different mutations that are expressed. They are associated with a worse survival in Hispanics if you express this mutation. So we're taking this a little step further and actually looking at biological differences. We're going to take these patients and these tissues and compare with RNA-seq and whole genome sequencing, along with the New Englander precision medicine people here at Cornell, as well as our friends in the pathology department, and really try to hone in on the biological differences between this specific populations. And I think being in New York City is a great place to be because we do really see people from all over the world. So you can directly compare these patients with the exact same clinical stage, the exact same kind of clinical demographics, and then look at the biology of their cancer and how that may be different. Because I think, this concept of personalized medicine and personalized cancer care, needs to really be stepped up as far as how we think of this population, this Latino Hispanic population, because we are a mixture of races. And I think that's going to keep advancing this concept. And I hope, I was able to show you guys this today. Thank you.
Thank you so much. We really appreciate your very interesting research. And I'm going to go ahead and ask for our next panelist slides to be brought up, please. If we could go ahead and do that, and I'll be happy to turn over the session. Again, a reminder, if you have questions for our panelists, please go ahead and submit them through the Q&A box. And without further ado, I'll turn it over to Dr. Reyna.
Thank you. I want to thank NMHA and LSS for providing this opportunity. I've actually had a busy year in which I was promoted to associate professor at University of Cincinnati and was recently recruited to take over and become the breast medical director and chief of breast surgery at Crozer Health. So next slide. I have no disclosures other than I did some of my own graphics, so please forgive. Next slide. So although this panel is supposed to be about surgical spotlights, breast cancer is very encompassing. So I'll be giving a little more overall discussion of the disparities that are seen within breast cancer. Next slide. So the Hispanic population is projected to grow from 15 to about 30 or 40% in the US over the next few decades. And the leading cause of death among all Hispanics in the United States is cancer, with breast cancer causing the most mortalities among the Hispanic and Latino women. This is even despite the fact that the incidence of breast cancer is lower in the Hispanic population than in non-Hispanic whites. In fact, Hispanics have about a 9.8% or 1 in 10 lifetime risk of breast cancer, compared to the 12% that we quote for all women. Next slide. Breast cancer specific mortality is decreasing overall. However, the rate of decrease is higher in non-Hispanic whites at about 1.8% per year, compared to only 1.1% decrease in the Hispanic and Latino population. Although some of this difference can be explained by the lower incidence of breast cancer, it can't explain everything. So why does the Hispanic population have lower breast cancer incidence, but slower decreasing rates of breast cancer specific mortality? Other factors come into play, and I consider them what can happen before the diagnosis, such as risk factors, the diagnosis for access and staging, and the treatment, the multimodal therapies that we use. Next slide. Breast cancer has become an interdisciplinary disease ranging from genetics, radiology, surgery, systemic treatment, and disparities can arise at any point along this journey. Next slide. As alluded to from my previous panelist, that it is important to understand that this is a very diverse population and ancestry plays a role. For example, Mexico and Peru have higher indigenous American influences compared to Cuba, which is more African, and the US is a mixture of all. Why is this important? It's because it affects the genetics. Next slide. It's been found that those with higher indigenous American backgrounds have a lower risk of breast cancer. And this actually led to the discovery of the ESR1 gene, which is protective against it. BRCA1 and 2 also play a role. But what's even more interesting is that a study of 1,000 BRCA negative Hispanic women with breast cancer, almost 5% were found to have some kind of genetic mutation. And so with the increasing availability of multi-gene panels and updated societal recommendations, genetic testing is being used more frequently. So it's important to know that there are other genetic variations out there because this could affect a woman's surgical decision. Next slide. The genes you are born with are important, but so is the geography in which you are born. About 1/3 of the US Hispanics are foreign born, and there are differences between those born in the US and those who are born abroad, basically seen in migration. Foreign-born Hispanics have even a lower rate of breast cancer compared to non-Hispanic whites. This may be due to environmental factors, lifestyle factors such as parity, alcohol use, breastfeeding, but there's a multitude of issues that contribute to breast cancer, and more studies are needed to further delineate these factors. Next slide. An area which disparities can also occur along the journey is the diagnosis. And this involves access to care or imaging, stage of presentations, and the subtypes. Next slide. According to a meta-analysis, Hispanics are actually less likely to get mammograms. In addition, a study of the NCCN database by Warner et al. Actually demonstrated that a mammogram is obtained. Hispanics have a longer time to diagnosis after an abnormal screening. So if they have an abnormal screening mammogram, it takes them longer to actually get their diagnosis compared to non-Hispanic whites. This can be from knowledge deficits, it could be from fear or economic reasons, but this also gives us some insight where some changes can be made. Next slide. So what happens after the imaging is done and a diagnosis is made? Well, it's been shown that the Hispanic population has diagnosed at a younger age. They also have a higher risk of presenting at more advanced stages, such as stage 3 and stage 4, meaning it's outside of the breast area, it can be further in the body, it could be in the bones or lungs. And this remains even after they adjust for age, income, and ER receptor status. So not only are they less likely to have mammograms, They're more likely to have advanced disease once diagnosed. This still only explains about 1/10 of the survival disparities seen in the Hispanic population. Next slide. The disparities can also be partially explained by the type of breast cancer at diagnosis. There are a variety of breast cancer subtypes. The most common subtype overall and in the Hispanic population is an ER/PR positive, HER2 negative breast cancer. This is actually the best behaving subtype. However, the Hispanic population are at a higher risk for more aggressive subtypes such as triple negative breast cancer and HER2 negative. So while it's most common to have the best subtypes, Hispanics are actually at higher risk for having the worst, more aggressive subtypes, which could also affect mortality. Next slide. After the diagnosis is made, then comes the treatment, and additional disparities can be found at this. Next slide. Breast cancer treatment is multidisciplinary. There's 3 main staples: surgery, medical or systemic therapy, and radiation therapy. Next slide. For a brief summary of surgery, and this is not breast fellowship boiled down, but this is a brief summary. Breast conserving therapy and mastectomy are the main options. Breast conserving therapy is the removal of cancer with a normal rim of tissue, and radiation is given if indicated. Mastectomy is removal of the breast with or without reconstruction. Next slide. When it comes to surgery, something very similar is seen in that delay that we had heard about earlier. It's found that once diagnosed, Hispanic women have a longer time to surgery versus non-Hispanic whites. 2 studies have also shown that there are higher rates of mastectomy in the Hispanic population compared to non-Hispanic whites when controlling for stage and patient factors. Now, both of those studies were population-based studies. When looking at an institution-based study, an article out of Stanford showed that Hispanic patients had to travel farther to get treatment. But once there, their rates of breast conservation, mastectomy, whether it was unilateral or bilateral, and reconstruction were not different, even after controlling for age and insurance status. So this suggests that it may not be an entirely population-based disparity, that there may be some things that we can overcome by increasing access to service, meaning identifying other things such as transportation or economic issues. Next slide. Endocrine and their colleagues made a conceptual framework that kind of highlights the higher risk of mastectomies and some of the factors that can contribute to this. Next slide. So even though there may be an increased rate of mastectomies in the Hispanic population, disparities in reconstruction still exist. The Women's Health and Cancer Rights Act in 1998 mandated that all insurance provide coverage for post-mastectomy reconstruction. But even so, women of color are less likely to receive it. Hispanic and Latino women are about 1/5 as likely to undergo reconstruction, especially if they are considered less assimilated or less acculturated. Even if they did receive reconstruction, they had higher rates of complications, including mastectomy flap necrosis and arterial insufficiencies. Next slide. So in terms of systemic treatment, which is also one of our ways to manage breast cancer, this population is also less likely to receive the recommended treatments. If they do receive it, they're more likely to have a delay in the initiation of therapy. The utilization of nurse navigators has been able to improve some of those delays. This population is also less likely to receive endocrine therapy. Now, this is important because if you remember that the most common type of breast cancer seen is ER/PR positive breast cancer, this therapy targets that cancer and is very effective in treating it. So decreasing the receipt of endocrine therapy could also be affecting outcomes and survival. So there may be systemic issues that we need to look at to help prevent the initiation of therapy. Next slide. So in summary, the Hispanic and Latino population is on the rise and has a lower incidence of breast cancer, but also a slower decline of breast cancer specific mortality. There are a multitude of factors that can affect the incidence and mortality in this population, whether it's before their diagnosis, at the time of their diagnosis, or even in their treatment of their diagnosis. Next slide. So we have many opportunities to identify areas to study, change, and affect the healthcare disparities in the Hispanic population when it comes to breast cancer disease, whether it's to raise awareness about disparities, educate the target population, implement different screening guidelines, increase access to imaging, staging, reconstruction. All of this matters, and we should take and continue to strive to identify and address these issues. Thank you. Next slide.
Thank you so much for that wonderful presentation. I am seeing some questions come in through the chat. Please, as a reminder, we're going to take these questions at the end of the talk. And Dr. Oliva-Shaffer, I'm going to go ahead and turn this over to you.
Hi, good morning. I have no disclosures. In 2009, cancer surpassed heart disease as the leading cause of death for Latinos living in the United States. Colorectal cancer is in the top 3 causes of death in the US for men and women, and Latinos are more likely to present at later stages of the cancer, which leads to worse prognosis and more likely to have reduced survival rates. Next slide. Overall death from colorectal cancer is decreasing in both men and women, most likely because of improved screening practices. But Latinos are less likely to be adherent with screening guidelines than non-Hispanic whites. Next slide. The incidence of colorectal cancer in young people has increased in the last decade, with projections to continue to increase. Young male and female Latinos under the age of 35 have seen this increase as well. 28% of the Latino population in the US is between the ages of 20 and 35. So they have been disproportionately affected by this rise. Next slide. So this brings me to March, which is actually Colorectal Cancer Awareness Month. Next slide. So I highlight colorectal cancer awareness because colorectal cancer is very curable if found early. And we know that screening does decrease mortality. And so unlike other cancers like pancreatic cancer or ovarian cancer that don't have great screening tests, colorectal does have a proven screening test that does decrease mortality. So in this study published in the New England Journal of Medicine, screening was shown to decrease mortality, 21% reduction in the incidence of colorectal cancer, 26% reduction in deaths from colorectal cancer, and 50% reduction in mortality from distal colorectal cancer. Next slide. Next slide. So some barriers for screening have been, So some barriers of screening have found to be cost, fear, or embarrassment. Facilitators were in-person health education, and importantly for you, physician recommendation. So if a physician recommended a screening, then there was an increased likelihood that the person would actually undergo that screening. Advance. And so we all know that the Latino and Hispanic populations, that they are not the same everywhere. So in this study, colorectal cancer incidence disproportionately affected men age 50 or older. And the authors felt that it was socioeconomic and perhaps cultural and lifestyle differences that were contributing to this disparity. Advance. This paper showed that instituting a navigator who would call the patient and clarify the screening plan increased their adherence to screening guidelines. And so what this tells us is that there are modifiable things we can do as individuals as well as a system to improve screening adherence. Next slide. So what are the guidelines? So these are the recommendations from the American Cancer Society, which recommends screening to start at the age of 45 for average risk patients, and earlier than 45 if they're of higher risk, meaning having family history, inflammation, chronic inflammation, etc. So for people in good health who are expected to live at least 10 years, screening should continue through the age of 75. Once someone reaches 76 to 85, then the decision becomes a conversation between the patient and the doctor, which should include things like personal preference, their prior screening results, overall health, as well as life expectancy. over the age of 85, then routine screening is no longer recommended, but obviously for symptoms, et cetera, depending on general health, a colonoscopy could still be appropriate. Next slide. And so the number one message to patients should be to get screened, no matter what test they choose. Next. So colonoscopy remains the gold standard visual exam, but many people are hesitant to do this because they feel maybe it's too invasive. And so there are stool-based tests that can be used. Next. So these are the stool-based tests. So the highly sensitive fecal immunochemical test. This should be performed every year in order to be an effective screening test. We also have the highly sensitive guaiac-based fecal occult blood test, also to be performed every year in order to be an effective screening test. And then there is the stool DNA, which most people recognize as Cologuard, which should be done every 3 years to be effective as a screener. If any of these stool-based tests are positive, then the patient should follow up with a colonoscopy. Next. The visual exams are colonoscopy, which should be performed every 10 years. And this remains, the gold standard for screening tests. There's also options for virtual colonoscopy, which should be done every 5, or flexible sigmoidoscopy every 5 years. So the visual tests do require a prep. And like I said, colonoscopy does remain the gold standard, but perhaps, one of these other tests is effective as long as they're done under the appropriate time interval. Next slide. And so, so we know that colorectal cancer is in the top 3 most common cancers in the US. Next. We know that screening does prevent mortality, but that Latinos are presenting later and have higher likelihood, next slide, of emergency surgery, which is usually associated with worse outcomes. Next. And next. But we have tools to fight this with increased awareness among our population as well as among physicians. Increased screening would decrease the mortality in colorectal cancer patients. And so I encourage all of you, no matter what your specialty, to remind your patients about colorectal cancer screening and continue to be their advocate. Next. So thank you very much to the organizers of the conference and to Dr. Minerva Romero Arenas for the opportunity to speak to you today. Thank you.
Thank you. If we can stop the slide share, I'd like to ask our panelists to please turn on your cameras again. We're going to go ahead and take a few questions that came in from the audience. And this is going to be first a question to Dr. Reyna. Dr. Reyna, what have you noted in your patients in regards to reasons or concerns of why they do not want to have mammograms, and how do you address those?
I think this is also similar to what is seen in the colorectal population that Dr. Shaffer was referring to, is that there's a lot of fear. And it's not so much the fear of finding something, it's the fear of finding something and then having the cost to deal with the treatment afterwards. And this population is much more uninsured than others. And so I think it's a combination between finding something and then not knowing how we're going to pay for it afterwards.
Dr. Shaffer, would you like to add to that?
Yeah, I mean, I think colonoscopies are not inexpensive. And so depending on your insurance status, that could be, it could be a financial issue. I think also a lot of people just, when asked, there's been qualitative studies looking at this. And when asked, they just don't feel like if they don't have any symptoms that they should undergo medical testing because they heard that a neighbor did it and, something bad happened to them. And so I think there is a lot of fear, both of finding something and then how do you deal with it, but then also that you're kind of looking for something that's not there. And so I think that when they hear, somebody had a perforation after colonoscopy or et cetera, then I think that gets magnified among, from mouth to mouth, and that can lead to it. And I think also it's a little bit unpleasant. I mean, I don't know if any of you guys have had a colonoscopy prep, but it's not pleasant. And so I think anything that people find unpleasant, they're probably less likely to sign up for.
Mammograms are also less pleasant, so it's the same thing.
Yeah.
Thank you both for your insight on that. I'm going to ask Dr. Dr. Villena-Vargas a question. The worst outcome amongst Hispanics, do these hold true even if access to care and environmental settings may be different amongst ethnic groups and subgroups?
We didn't really look into, at least I didn't look into the kind of the demographics, the economic demographics and things like that. But well, the interesting thing is that the worst in prognosis for these patients was only seen in the EGFR mutants. If you look at the EGFR wild type patients, the Hispanics did better. That's something that's known, as people have brought up this concept of the Hispanic paradox, which is even with worse economic factors or worse socioeconomic factors, the patients actually do better with from the similar cancer diagnosis. And that kind of, it wasn't statistically significant, but it did hold true in the EGFR wild type. So really the goal is to look at the EGFR mutant patients, and I think there might be more of a biological answer to this, which would be interesting if those, if the different ethnicities or races that have the EGFR mutant, if they behave differently amongst each other. And that's what we're kind of honing in on in a biological sense. But we didn't look into the socioeconomic. Unfortunately, it's a little bit out of my scope.
Thank you for that, and definitely a very interesting point. Hopefully with increased participation in research, you would be able to assess that in subgroup analyses. There's another question that I actually wanted to ask Dr. Mendoza. I think that you definitely raised the concern about occupational exposures in our community. And, would you have said the occupational exposure from COVID certainly follows the pattern of your trauma patients?
Oh my gosh, absolutely. I think that's what showed that this group of people who are really at high risk jobs, who are essential workers, often construction is considered essential, as well as, most city services. They're underpaid, they're overworked, and they're overexposed to all types of hazards, COVID-19 being the latest.
Thank you for your insight. We look forward to learning more about your experience in Boston. There was another question that came in through the chat. This is to Dr. Reyna. Dr. Reyna, do you know if the disparity on breast reconstruction is due to a low density of plastic surgeons in Hispanic communities or due to fewer plastic surgeons accepting specific types of insurance?
I think it's a multitude of factors. Yes, access to plastic surgery is important, and I think part of it is insurance related. But if you remember that the Hispanic population also presents with later stages, which means that they're going to get chemotherapy typically, or they'll get radiation afterwards. There's also a lot of comorbidities such as higher BMIs or ASA classifications. Sometimes they smoke. They've been shown to have more abdominal surgeries. That ties in kind of to our trauma related speaker that we had earlier. And so all of those factor in. And so they're also not as great of candidates from risk factor perspectives for reconstruction. So not only are we at a higher risk in terms of complications, we also have less access. And so between those two is what I think it comes down to.
That's a fair point. I'm going to ask two more questions, and I'm going to ask that you keep your answers brief so that we can wrap up in time. One of the questions came in, a lot of the issues discussed today seem to be intersectional in nature. Insurance access, the availability of care, access to care. As surgeons, how can our field work towards addressing these issues inside and outside of the operating room?
Gosh, that's a really great question, one, and it's very complicated. I can say from the physician standpoint, it means a lot more phone calls. It's asking for a little bit more favors. It's asking case management to be creative. It takes more energy, but it's possible. From the outside perspective, as a civilian, as a citizen, it's voting. I would recommend being active politically.
Great point.
I think just briefly, one of the ways that have been kind of shown to be successful is as a help, advocating in terms of within your healthcare system for partnerships in the community. Because I think that community outreach is very important. And although we're not, you can't outreach and say, come get surgery, but you're kind of meeting the needs of the patient population before they get there or meeting them when they need it. So I think that partnerships with community partners, the healthcare system with community partners is an effective way of doing that. So being advocates for those types of partnerships is important.
I think, hosting multidisciplinary sessions like this also help us drive a lot of these diseases forward, because we don't work in isolation, right? And we work with our colleagues in primary care and in other specialties who are helping guide those referrals appropriately. And so I think this is a really great opportunity as we partner with NHMA to really communicate in multidisciplinary fashion with our colleagues.
I think, a lot of it is, like Virginia was saying, it's a lot of patient education. A better educated patient will always do better. And unfortunately, it's hard. Outreach is hard, especially on a subspecialty level. I feel like the primary care doctors for bilingual patients, for patients that are in a specific culture, are easily reached. But I think on a subspecialty level, we don't do a good job, especially large academic centers. I feel like don't do a good job. And they're starting to, now that it's like the hot thing to do, but hopefully it keeps staying that way.
Yeah, thank you for that insight. Okay, and we're gonna wrap up with our last questions. Our last single question. What type of support have you had from your hospital system or the leadership in your department, specifically relating to tenure track, time to pursue your research, and balancing clinical responsibilities?
I'll just chime in quickly here. So I think all that has to get negotiated before you actually start your job, because that's when you kind of negotiate your protected time, et cetera. So I didn't do that. So I was pretty much came in 100% clinical, which makes it very difficult to do all these other things that you're interested in. Then I now have protected time because I'm the program director for our fellowship. So as you kind of do things that have funding associated with them, like getting grants and kind of administrative stuff, then protected time comes with that. But other than that, I think unless you negotiate it right when you're starting, it's really difficult to go back and then say, I want more resources or more time.
Anybody else would like to comment?
Yeah, that's a very complicated question. I saw it initially. I'm like, how do you answer this in a brief manner? Yeah, I have to agree that the conversations before employment, but every hospital I interviewed at offered different things, different advantages and disadvantages. There is no such thing as the perfect anything. There were certain jobs that emphasize research, but de-emphasize clinical work. And so it's hard to get that balance. As you travel through your training, you have what kind of balance, what things you're willing to sacrifice, and a major emphasis for you. And I think that helps you choose the institution you end up working with.
Thank you so much. I want to wrap up this workshop by thanking our panelists for providing these wonderful presentations, giving a spotlight on surgical disease in our community. I'm going to invite you to join us for our second workshop, which will be starting in just a few minutes. For everyone else, if you're stepping out, enjoy the rest of the conference. And please don't forget to connect with the Latino Surgical Society.